Good morning. Welcome all to Concurrent number 11, Changing Remote Patient Monitoring Strategies in the Midst of COVID-19. My name is Jeff Kingdon, and I am part of the TELUS Health team. This session is a panel discussion format. If you have any questions or comments for our panelists, please type them directly into the Zoom chat, and we will address them as time allows. You are also encouraged to connect with speakers after the session via the virtual event platform. I'd now like to welcome our panelists to the virtual stage. Lisa Saffarek. Lisa is the Director of Virtual Care at Island Health. A registered nurse by trade, Lisa has a varied background in healthcare, including research education, informatics, and leadership. Virtual care aligns perfectly with Lisa's passion for supporting people to receive care in their homes and further integrate technology into community-based care. Welcome, Lisa. Dr. Vern Behl. Vern is the Senior Medical Information Officer in Digital Health for Saskatchewan Health Authority. Vern completed his medical degree followed by a residency in family medicine and a fellowship in emergency medicine at the University of Saskatchewan. He currently practices as an emergency physician and transport physician in Saskatoon. And last but not least, Pam Smith. Pam is the Acting Executive Director leading patient empowerment and public health COVID-19 digital health strategic initiatives with the BC Ministry of Health. Pam's background is health informatics, and while she has spent time working outside of health through the course of her career, all roads have consistently guided her back to health, which is a great choice, Pam. Just getting into our agenda here. So in the time that we have this morning, I'm going to do a brief overview of the TELUS Health role across the virtual care ecosystem, specifically home health monitoring. Then we'll get into our questions for the panelists, and followed by a recap and any questions that we have from the audience. First off, a bit about the TELUS Health ecosystem. TELUS Health is proud of the role we've played across the digital health ecosystem. We play a role in providing many services and supports for citizens depending on where they are in the various stages of their healthcare journey. All of these services, independently or in tandem, strengthen connections, inform decisions and interventions, and support better outcomes for patients and better provider experiences. One of these services near and dear to my heart is TELUS Home Health Monitoring. TELUS Home Health Monitoring has been in place for nearly 10 years, with our original client here in BC, as well more recently with deployments in Alberta, Saskatchewan, and just a couple weeks ago, Manitoba. HHM enables clinicians and care teams to remotely monitor patients through the sharing of biometric and non-biometric data using patients' own devices and program-provided devices as well. Across our HHM clients, we've had over 30,000 patients monitored on our platform, a sizable portion of which was for COVID monitoring in the last couple of years. Now, speaking of that, let's get into our discussion with our panelists, and I'll just jump back to our agenda slide here. So panelists, if we can just provide some context for the audience about what everyone's experience is with COVID-19 home health monitoring or remote patient monitoring, given their role and organization. And so I'll turn that over to our panelists. And why don't we start with Lisa Saffarek from Island Health. Lisa?
Many thanks, Jeff. We were fortunate to already have a really strong remote patient monitoring program. We also were well positioned to respond to the pandemic with virtual care, thanks to the investment of our and support of our executive and our board. So we actually had a COVID-19 case and contract remote patient monitoring program up, so supporting our public health to use RPM to do their case and contact tracing within 2 weeks of COVID hitting the island. So that just speaks to that public health team and how flexible and agile they were and willing to meet willing to work with me when they'd never even met me before or knew anything about this. So they monitored well over 10,000 people before pivoting and changing how they did case and contact monitoring. But what we quickly realized, and after a couple of those horrible news stories where people became symptomatic with COVID and then passed away at home, we realized we also needed a clinical program in place. So again, incredibly supportive organization that allowed me to second some community health nurses and set up intensive home monitoring, where we did clinical monitoring of people with COVID, and that remains in place now. With I think we put well over 600 people through that, ensuring that they're safe at home and they know when to seek urgent care. And I mean, it's scary to have COVID and feel short of breath at home, and that has been able to support them to stay safe, to feel secure, and that's now been operationalized by the organization. So that has, we also we expanded our chronic disease monitoring because people were having a hard time getting into their primary care providers. So we added hypertension and CKD to our heart failure, COPD, and diabetes monitoring. And we also supported the north of the island with gestational hypertension. There was a lot of midwives and GPs who were very concerned about, these rural and remote, often First Nation moms having to travel for their appointments and getting exposed. So we were really excited to be able to support those moms as well.
Excellent. Thank you, Lisa. Right over to you, Pam Smith. Please tell us about your role and how BC Ministry of Health played a part in responding to COVID with remote patient monitoring.
Thanks, Jeff. Yeah, and building on from Lisa's update, our role as ministry was really not to get in the way and to support our health authority partners as best as we could with the program and services and the population they're supporting during a very stressful time for many, many people. So that was our key goal. So it was giving the health authorities the autonomy, the ability to do what they needed to do, and being there as a support, however we could, to ensure they could stand up their programs. And a really key part of this was being able to be creative and expand home health monitoring for COVID contact tracing so that people could stay home, we could follow up. And as Lisa said, regardless of the circumstance, minimize that need to travel or be exposed if that wasn't comfortable. So it really came down to how are we helping people during this time? And that was key. And it was, in some cases, introducing them to a new service, new technology, but remembering this is all about people on both ends, and we can't lose sight of that. We're providing healthcare, and so the care part is really key. But I would say that for the ministry, it was how do we support, how can we help, how can we learn from this and continue to provide this service.
Great, thank you, Pam. And Vern, out to you in Saskatchewan.
Thanks, Jeff. Appreciate that. Yeah, so in Saskatchewan, unfortunately, we weren't quite as lucky to, as BC, to have already had the remote patient monitoring stood up before COVID hit. We had many discussions about it and had already had that as a plan and on our roadmap. I agree with you, Pam. Our ministry was very supportive with us as well to allow us to stand up home health monitoring at the beginning of the pandemic. So we actually pivoted and switched and got teams in place very quickly so that we could launch the product for COVID and at the same time also thinking about how we do this for the future as well, right at the beginning, knowing that that was on our agenda already. So within a few weeks we got the teams together, and it did take a while. It did take a bit of time to get the resources in place, the buy-in, the understanding, how this helps, where this can go to. But we did it relatively quickly, and we were able to start monitoring actually lung transplant patients as a chronic condition first, even before we hit COVID patients. So we did start with a chronic condition and then moved to the COVID case and contact monitoring. And throughout this last couple of years, I've been trying to expand that process and see what we can do with true remote patient monitoring from a provincial standpoint. And that is actually our goal, and where we want to get to in the future is one centralized monitoring from a provincial level, so that we can take care of all our chronic conditions and our patients, and as has already been said, gain all the benefits of remote patient monitoring.
Great, thank you, Vern. Just for our audience, when Lisa and Vern and Pam and I were prepping for this session, we talked about how we wanted to bring a new lens to this discussion. And so in addition to lessons learned, through everyone's experiences in providing remote patient monitoring services during the pandemic, you can imagine that there were revelations and lessons learned about that could be applied to the business as usual provision of remote patient monitoring services in a non-pandemic time. And so and this is where we get into the meat of our discussion this morning, we can go back to Lisa and we can talk about what were some of those revelations, Lisa, that you experienced or lessons learned that you're hoping to inform and influence your provision of virtual care for Island Health going forward.
Thanks again, Jeff. Applying that equity lens was always something that I've attempted to do, and I've always challenged our team to do, but it was so evident of the requirements to ensure we were not further marginalizing the marginalized. And so, where even our teams, like even if they weren't using the remote patient monitoring technology, might support someone over the phone, that person, even if they have a phone, they may not be able to have the minutes, they don't have the network, like they don't have that access. And so really part of that, of the assessment of that person's needs were what were their digital needs, right? What did we need to support them? We were able to, provide them with LT-enabled tablets to participate in the monitoring. Some of them were frightened to carry those. They were scared that they would be assaulted if they did those, because we responded to a lot of outbreaks in people that are housing challenged and stuff. So there was a lot of quick learnings there and a lot of having to be agile to make sure that we were doing what was best by that person and along with their care team. And again, I really want to call out our public health team, in terms of working closely with us and giving that kind of feedback and stuff. Our community health team had to pivot their intake. Their intake was completely based on providing in-person care. They needed to shift that as they were now providing virtual care across the island and such. And the other piece, we worked a lot with cohort housing, where we were able to support people who couldn't isolated at home or didn't have a place to isolate. And I have a great relationship with some of the local hotels where I popped in every day to pick up the oximeters and replace the cell phones and the tablets and stuff. And I really love what you said about it's caring and it's the person on either side, Pam, because that's exactly what it turned into for us. And that allowed us to really apply that equity lens that was just so important. And we continue to do so as we find better ways to work with all of our First Nation communities. It's a big piece of how our community virtual care team, which is a regional remote patient monitoring team within Island Health, is looking to find ways of better access to devices, to the services and stuff like that, and determining what the needs are of those communities and how they would like us to support them.
And Lisa, just noticing a question in the chat, and a question from, I'm sorry, I might get the name wrong, but Elise, maybe? And she's wondering, can RPM programs free up services for those without access to digital tools and the internet? I think, Lisa, that's just what you're exactly talking about, is that?
Exactly. Yeah, so the tablets are locked down, LTE enabled, and then part of the support of Island Health is I was able to purchase a number of cell phones, flip phones, where we could support those too, because we can do virtual visits on the tablets, but it does depend on how good the network access is. But just making sure that that person had a cell phone to be able to connect with their monitoring nurse as well was really important. So we just met, we have our basic components, of Bluetooth devices, biometric devices, and a tablet, but we also needed to make sure that they had a phone, right? Let's get down to the basics.
Mm-hmm.
I was going to comment too, and I see that there's a couple other comments on the chat as well here, right? And I agree with you, Lisa, right? It's about getting the technology into the patient's hand, but virtual care is about care, right? Just a different way of doing what we currently do and how to provide that. But the technology is required, not just the phones, but the internet access and the infrastructure as well. But it does increase capacity. Right, so when we have the care delivered virtually, it does free up the teams to do other things. So if we can do it efficiently, effectively, then our teams are able to actually see other patients as well at the same time, maybe in person, not just virtually. So it really does expand that whole experience. We went through this process too of how do we deliver that technology, right? And how do we get that equity, make sure that people have it in their hands, whether it's a bring your own device, is it on your own phone? We went through a process of actually purchasing tablets from the SHA. The SHA purchased the tablets and we sent those out as opposed to TELUS tablets as well. We did have a cohort of TELUS tablets as well with the biometric devices. So kind of tried a few different strategies across the board. Again, those are part of the lessons learned about how we manage those devices and you know, how we get them out to the patients in a relatively quick fashion, get them back, ensure that they're able to connect with whatever connection they have, whether it be LTE or Wi-Fi, where they're at, depending on their network capabilities, because that is not equitable across the province as well, especially the northern parts where cellular coverage is very limited and there's not a lot of Wi-Fi. So it's a bit of a challenge to figure out where people can actually use these devices. Mm-hmm. And then I think the other piece is how that links in with our standard telehealth and other virtual visit capabilities, how we connect all the virtual care strategies together so that we can you know, utilize everything in the most appropriate manner.
Fantastic, thank you, Vern. Pam Smith, maybe over to you. You know, and you touched on it earlier, you know, from an administrative leadership perspective, from your position with BC Ministry of Health. You talked about, I think you touched on, you know, needing to provide you know, the role of providing the support to the health authorities and to the patients that they support. Anything more to expand with respect to that?
I would say overall, I think the key is, you know, as we continue to take advantage of our digital options and how far we've come over the past 2 years, knowing that this problem space existed well before the past 2 years. It just came front and center because of circumstances, that we don't lose those themes that have come up through this panel. And I'm sure folks who have joined us appreciate as well, the accessibility angle. And it's not just about technology accessibility, it's that language, culturally appropriate, safe, comfort with the tools that are being provided. And that we're not adding additional burden to the patient or the clinician providing the care. So again, how do we bring these things in, introduce them, keep them moving, recognizing that there's, you know, existing processes, interactions, relationships that we need to support. So I always like to bring it back to that again, the people side of it, and that our digital supports are the supplements. And we just have to keep learning and improving how we do that and work together ultimately to improve that experience.
Thanks, Pam. One other thing, if I can just add as well, that we were talking about while prepping for the session, from my experience, you know, as having a front row seat to BC's response to the COVID-19, you know, just the logistics and operational challenges. And in BC, we have a model where we have TELUS technicians involved under business as usual delivery of chronic disease, home health monitoring services. And so during COVID, with the increased emphasis on social distancing, that limited our ability to have TELUS technicians in close proximity with our patients, and we needed to rely on couriers. And while we had always spoken in the past about you know, moving towards more of an option to have BYOD models or have self-guided models for the right subset of a patient population, when we had to pivot quickly and we were thrown into that environment and using couriers and not having access to our regular you know, delivery models, you know, as you might think, it wasn't all smooth sailing, and definitely some lessons learned. And Lisa, we've talked about this before, that there's definitely value and a use case for in the future for adopting more of a BYOD model, or having patients, you know, get started on HHM being self-guided with the right videos or the right documentation, but it just needs to be done properly with the right processes. And you might not get the processes right at the onset, but through iterations, it can be done, and it can be done successful.
Yeah, and coming back to what Pam said, really meeting the client with where they're at, and like our average heart failure client is 80 years old. So, a small way bill, packing tape is not going to happen for them. But, we do have to work around ways and work with our patient partners. I'm really excited that Jim, one of our patient partners, is actually here with us today, but ensuring that we have a process that meets their needs. But I'm very excited for the world, the moving forward for, opening the world with BYOD. That was what we've done mostly for our COVID-19 remote patient monitoring. But again, you have to have that equity lens applied and ensure that you're making access to devices and network as required.
Excellent. All right. Well, with that, I know we've got a bit of some Q&A going on in the chat right now, which is fantastic, but I'm just going to jump to our wrap up or discussion points recap, and then open up the floor for some questions here. But so just to recap the key points that we've made this morning so far. Provision of remote patient monitoring services for COVID-19 patient populations. As Lisa's been saying, it reaffirmed a gap in equitable access to healthcare for marginalized and vulnerable patient populations, and just did more to shine a light on that and how that needs to improve, going forward for all of our virtual care strategies. As Pam mentioned, opportunities exist for enhanced ministry oversight and leadership to help authorities and health authorities and patient populations receive the right support at the right time, and of course, keeping it patient-centric all the while. Temporary removal of some barriers made by the provision of care during COVID made provision of care relatively easier from a patient-provider perspective. And by comparison, you might assume that business as usual care in a non-emergent setting seems that much more prohibitive, and so as Vern was saying, and what we're talking about today is what can be done to remove barriers to better, more efficient care during regular time, something that I'm imagining that we're going to be continuing to talk about for quite some time to come. And lastly, just mentioned at the last part there, operational logistic hardware delivery models. As our virtual care strategies evolve going forward, having those options and those mechanisms of better utilizing more efficient use of remote patient monitoring funding, and having self-serve HHM and BYOD HHM in place can be done successfully. It just needs the right processes and the right inputs from all stakeholders. So with that, why don't we just jump over into our chat here and take a peek at our questions. One question that came in earlier, and I'll actually, this is a good question here. And for any of our panelists or all of our panelist members, question: if you had complete autonomy for a day, maybe you're the sovereign for a day, and had largely no administrative barriers, understanding that we all have to have a minimum amount of administrative barriers, what is the biggest thing or things you would do to drive scale and adoption for virtual care programs in your organization? We saw a lot of scale and adoption with COVID, and what could be done to get something comparable or similar in non-COVID patient populations? Anybody want to try to tackle that one?
We only have 5 minutes left, Jeff. And I expect you want to hear from Pam and Vern too. So I'll be real quick. I'll be pointy here. So if I had complete autonomy, we would have one digital front door, not just for our patients, as we so talk about, but also for our providers. They're operating within our EHR. They're using all these incredible tools to support them to deliver care better, safer, with cultural humility. But they don't even know that they're operating with other tools. They just know that they're working from within our electronic health record. Everything works seamlessly. So integration, integration, integration. My other big thing that I would like to talk about is digital and health literacy. And we would have full supports in place, again, not just for our patients, but for our providers as well. The technology's moved forward, but I don't feel like our support of our providers has as well. So they're trying to deliver these group education, but they're struggling with how to use Microsoft Office tools and bring their, how to moderate a virtual education group and stuff and everything like this. So we need to better support them. Pass it over to Pam and Vern.
That was great, Lisa. I will very quickly add, I agree, continuity of care and information is key. And then coordination of our digital tools. So speaking to that digital literacy, education and awareness, not constantly changing out tools. So I would stop there.
Yeah, I 100% agree. I think the information flow piece is probably the biggest key. You can't make good decisions without good information. That's kind of the basis of any decision-making process. So that information flow, ensuring our digital tools actually work together, having that interoperability. And as you said, Lisa, I agree 100%. It's about making it easy. Right? Every other app we do, every other thing we do, you don't even see the back end. We don't see how it all connects in there, but there are so many tools out there so that when the providers and patients are utilizing these, just to make it simple, I would try to get everything simple and working together. The other thing is looking at the whole thing as a whole. We tend to silo these things, right? In virtual care and EHR and all these other pieces of digital tools, but they are very, very connected. And if we want to have connected care, we need our digital tools to be connected as well. So I would just ask the ministry to pay for it all and get us everything we need.
Excellent. Thanks, Vern.
I love
and I'm just
a provincial model. Sorry, Jeff. I love that we have a provincial model in BC, and I hope we can continue that, Pam. Just going to put my plug in there. I love our relationship with the Ministry of Health and my relationship with the other regional health authorities. I think it makes our remote patient monitoring program so much stronger in BC.
All right. Just looking at the chat, I see Narissa and Lisa, you were chatting about cost benefit outcomes and demonstrations there, and I imagine we're just about running out of time here, but Narissa and Lisa, Lisa's done numerous evaluations on home health monitoring and has been able to demonstrate cost avoidance, and I'm sure, Lisa, you'd be happy to share that information with Narissa if she reaches out.
Absolutely, more than happy to. Narissa, don't hesitate, but I can send you our 70-page report from our last one, but I can summarize it in that we showed a cost avoidance of well over $3,000 per client who participated, and through that acute care reduction, and that doesn't even include, the impact on their primary care and stuff. And we have had excellent support. Our primary care providers love this service because they have more understanding of what's happening with their patients at home and how they're progressing or how they're not progressing.
Fantastic. And Megan, I see that offer to chat about hardware for HHM, and that's my jam, and I'll be reaching out and we'll bond over that. But with that, we're a minute out here, and I just want to thank all of our panelists for a very engaging, very quick discussion that feels like 5 minutes on remote patient monitoring strategies. Next up, I would like to invite all attendees to join our exhibitors for networking and discussions in the virtual trade show, accessed at the top of your screen, and we'll see you there. And thank you everyone for attending. Really appreciate it.